You may begin.
My name is Harry.
Hannah, Harry.
We are presenting group. We are group T. We are presenting our concept regarding the rheumatoid arthritis and osteoarthritis is fall underneath the concept of inflammation. Basically, rheumatoid arthritis is chronic inflammation disorder as autoimmune, as it's mostly affect women than men. Osteoarthritis is age-related and mostly kind of genetic disorder, plus obesity or some protein problem in the body, and mostly affect the joints. Both affect joints, but the osteoarthritis affect the joint movement than the rheumatoid arthritis. Okay.
So the pathophysiology for RA is RA is a chronic systemic autoimmune disease that primarily affects the joints, causing swelling, painful swelling, and it can also result in bone erosion and joint deformity. Although the exact cause of RA remains unknown, recent findings suggest a genetic base for disease development. Environmental factors such as smoking and infection may also influence the development and the rate of progression and the severity of RA. The complex interaction of immune modulators is responsible for the joint damage that begins at the synovial membrane and covers most structures. RA primarily starts at a state of persistent cellular activation, leading to autoimmunity and immune complexes in both joints and other organs where it is manifested. Various phases. So you have the initiation phase. This is due to non-specific inflammation. The amplification phase due to T cell activation, and the chronic inflammatory phase with tissue injury due to cytokines. And cytokines are small protein, and they're used for cell signaling.
So some genetic factors for rheumatoid arthritis. For the most part, they typically affect women, and it's normally women from that are younger to middle age or with the presence of Epstein-Barr virus. In comparison to osteoarthritis, it's mostly people who have a family history of osteoarthritis or people who have the presence of RA. There are also congenital anomalies. In the book, on page 320, it gives a nice chart to tell you exactly the differences when it comes to genetic factors as well as some tests.
There are a lot of manifestations regarding the system. Normally, RA affect more system than OA, osteoarthritis. So definitely there is both systems, both disease complications regarding systems. For the RA, there is a respiratory problem like pneumonitis, pulmonary hypertension, cardiovascular, then I have vasculitis, pericarditis, myocarditis, then inflammation of the smooth muscle around our covering muscle or cardiac muscle. Neuromuscular, that's going to be a neuropathy or peristalsis. Endocrine is diabetes members or a thyroid problem with the hypothyroidism or hypo. Drive is that's reproductive. Pain is kind of inflammatory. The immunity is chronic immunity and chronic pain or acute pain, depending on what phase in RA. Inflammation on joints, joint muscles or synovial or cartilage. With the osteoarthritis, there is a particular manifestation regarding the pain. It could be psycho, because the chronic pain could lead to change in a mental status or change in a body concept of body image, and definitely the cortisol level gonna be increased because of the chronic pain. both diseases, that means it's gonna have risk for the infections, or super infection and other things. With the OA, there is not really more systems that are affected compared to the RA. Gonna go with the diagnosis.
The diagnostic tests for osteoarthritis and rheumatoid arthritis are very similar. You have the ESRs, the end sediment rate. You have the C-reactive proteins. You have there are no specific tests that diagnoses RA or osteoarthritis, and so there's physical exams and family history also would help to the diagnosis for these diseases. And you have a complete blood count. You have X-rays, MRIs, rheumatoid factor, DNA, anti-nuclear antibody, and synovial fluid analysis. And those are the similar for both RA and OA. And for priority nursing care, you have energy conservation, management of fatigue, and rest in between, rest when necessary, taking medication on time, and assess blood-related drugs from NSAIDs in case they're taking medication that increases bleeding.
So when it comes to the management, the nursing care, and the collaboration between the entire medical team regarding the patient who has RA, with RA for the most part, because it's a autoimmune disease, there is really no surgery that you can do to really fix it. Most of the time, management comes down to drugs or pharmacological needs and non-pharmacological uses. So with RA, you have multiple different types of drugs. You have anti-inflammatory or analgesic. You also have the DMARDs, which would be disease-modifying anti-rhythmic drugs, which also are broken down into immunosuppressive, disease-modifying ones. And for the most part, all of them will, the main point is to reduce the inflammation in the joints and further prevent erosion of the joints. A lot of those medications have a lot of adverse side effects, mostly very strong infections, especially immunosuppressive ones. You also have with OA, most of the time the drugs will be for just managing the joint pain. With that, because it is not an autoimmune, you would have surgical means to fix it. So there are total knee replacements, total joint replacements, total hip replacements, as well as all of those, and add, instead of replacements, arthroplasties. With those, those surgeries are contraindicated with anyone who has an active infection, advanced osteoarthritis, or a rapidly progressing inflammation.
So the patient teaching for RA would include, you should tell the patient that if he or she doesn't follow the prescribed exercise program, then their muscle strength and joint mobility could diminish. And you also want to encourage the patient to eat a balanced diet, including foods high in vitamins, proteins, and iron, and these can promote tissue building and repair. And also for osteoarthritis, you want to encourage good body mechanics, and you want to warn them of potential complication like or GI complication or stress ulcers, and you should also tell them that they should stop exercising if pain occurs.
Some non-pharmacological means, can you just add that in? Are adequate resting, proper positioning, using heat or ice packs,
Rehabilitation, massage therapy, Tai Chi, low stress yoga,
Hypnosis, acupuncture, guided imagery, music.
weight management.
Any questions? Got some questions?
Yes, go ahead.
Yeah, you mentioned hip and knee replacements, surgeries. Anything we should know post-operatively, what to or how to care for such patients, how to position them, for example?
So you want to relieve all weight from the one side that is affected with the surgery. When it comes to moving them outside of the bed, you do definitely want to encourage mobility after that, but to a certain extent. You do also want to give them any type of anticoagulant like warfarin or Coumadin. You want to
Need to elevate the
was there something specific you were looking for? You don't want to move them outside because it's still healing outside that.
Yeah, if you have knee surgery or knee replacement, you gotta elevate these are affected. Then if you have hip surgery, you're not gonna move nothing on it because that's really more vulnerable. Yeah. And definitely we gotta use the heparin throughout the hospitalization. After that, it depends on physician whether commodine or not, depend on the PT label or something like that. And definitely not like where you're not gonna put the too much weight on the same,
Any more questions? Okay.